and it is my pleasure to welcome you to VYA's first webinar. You may have noticed that we changed the name of this webinar from Investing When It Counts, Partnering with VYAs to Improve SRH, to simply Partnering with Very Young Adolescents to Improve Sexual and Reproductive Health. We did this to avoid confusion with a soon-to-be updated Population Council publication on VYAs titled Investing When It Counts, which will be published this summer. In addition to our first webinar, the VYA Alliance is also excited to launch the VYA Clearinghouse Toolkit on K4 Health. More on this later in the webinar. So what is the Very Young Adolescents Alliance? It is an alliance of 4 founding members to include Georgetown University's Institute for Reproductive Health, Save the Children, Plan International USA, and DSW for the purpose of raising awareness of the importance of VYAs, testing innovative programs, and making program practices, tools, and guidelines widely accessible. Today we will have 5 speakers who will be presenting on 5 different topics on VYAs. Our first speaker will be Dr. Bob Bloom. Dr. Bloom is the William H. Gates Senior Professor and Chair of the Department of Population, Family, and Reproductive Health at Johns Hopkins Bloomberg School of Public Health. He is a leading authority in adolescent health, sexuality, and healthcare issues. Dr. Bloom will be speaking to us on Why Adolescence, a conceptual framework for understanding VYAs. Dr. Bloom?
Good morning or good afternoon to everyone. Good evening where I am and to my colleagues in the East. It's a pleasure to be here. I'd like to set the context for this webinar. So when we look at young adolescents, a few statistics that are worth pointing out. First of all, we see that the vast majority of young adolescents, as is true for adolescents in general, live in low and middle income countries, over 85%. We know that there are very specific vulnerabilities that young adolescents, and particularly young adolescent girls, have. For example, 2 million young adolescents get pregnant. That's girls under the age of 15 get pregnant every year. The vast majority, 90+%, occurs in marriage. So this is a significant issue, and a significant issue worldwide. It's disproportionate in some countries like Bangladesh, Brazil, the DRC, Ethiopia, India, Nigeria, where these are particularly salient issues. It's also worth noting that there are some positive trends, and that is that we have seen a reduction when you look over a 30 to 40 year period of time, both in early marriage and in early pregnancy. That said, this is and remains a global issue, and child marriage remains a very, very significant issue. Just to put it a bit more in context, in sub-Saharan Africa, more than a third of 10 to 14-year-old girls live with neither a mother or father in the household. 30% are working in sub-Saharan Africa. In Asia, about a quarter. In Latin America, about a sixth. So being out of school, excuse me, and working almost always in the informal economy is a significant issue. We know from research that about 15% of young adolescents have engaged in sexual intercourse in sub-Saharan Africa, and about a third in North America, Latin America, the Caribbean, and Europe. So early sexual debut is also a significant issue. So it's with that as a backdrop that I just want to share a way of thinking about some of the issues at a multi-level framework. Some of what we know and some of what we think. So starting with a national level, we see that laws that relate to family planning and family planning access do have significant impact. Many of the other laws are what I would refer to as enabling contexts. So laws, for example, that protect young people against early marriage, laws that protect against gender-based violence. There is not good evidence one way or another that these laws have profound effects, but they do set the political stage and set the context that is very important. Secondly, when we look more proximally at the context in which young people live, at the community level, there we begin to see many more direct effects. So the norms and laws of the community, and when I say laws in that context, I'm talking about informal laws, do have a direct effect on child marriage. They have a direct effect on school going, even if schools are accessible. The cultural and religious norms of the community have a great extent in impact on what happens to the outcomes for young people. And so when we think about effective programs that improve outcomes for very young adolescents, there's some good evidence that engaging the community is really critical as a framework and a context. More proximal to the individual, closer, are school and peers and family. And we know that school is protective in many important ways. We know that young people who attend school do better. The World Bank has shown that for every year a young girl is in school from the 7th grade on, her risk of adolescent pregnancy decreases by 7%. That's compounded each year. So keeping girls in school makes a very significant difference. We also know that schools can be a source of vulnerability for young people, both because of gender-based violence that they can experience in the school setting and on the way to and from school. But that said, overall, school remains a highly protective environment. And as a strategy that improves the health as well as the social well-being of young people, matriculation and engagement are protective. And when I think of engagement, I'm really talking about the opportunities to engage with an adult in school, where there's both caring and expectations for school achievement. While I'm on the topic of engagement in school achievement, the evidence is overwhelming from around the world that family expectations and parental expectations have a huge, huge impact on the outcomes. Rebecca is going to talk in a few minutes, and Rebecca, you said something, a quote from Nepal, or a slogan from Nepal that just rings in my ears about this issue. And that is that there are those who say educating a daughter is like watering your neighbor's garden. There's no payoff in it. But the reality and the evidence is so much to the contrary that there's huge payoff in it. So parental expectations for school participation, school enrollment, school achievement have, again, very real impacts. Delaying marriage, reducing risks of HIV and sexually transmitted infections, as well as pregnancy. All of these factors are filtered through the individual and the individual's vulnerability. And so we know that the age of physical maturation makes a difference. One of the things that we are seeing throughout the world is that the age of puberty is declining. In low and middle income countries, it's declining primarily because of improved nutrition and sanitation. In high income countries, it's occurring because of environmental toxins, increased exposure to light through computer screen time and mechanisms such as that. And so we see these various forces and factors playing out with a decreasing pubertal age. We also know that this is a period of time when both the area of the brain that controls more sophisticated thinking, the prefrontal cortex, and the part that regulates emotions begin to develop. And the emotional area develops before the other parts of the brain and before the prefrontal cortex. And what that means, in fact, is that adolescents, and particularly young adolescents, are much more sensitive to rewards than to punishments. The evidence is strong that punitive approaches to adolescence in early adolescence has less impact than it does in childhood and adulthood. But using a rewards-based approach has more impact. So I present this as just a framework to think about very young adolescents. Let me turn it back to you. I look forward to the rest of the dialogue.
Thank you, Dr. Bloom. Thank you, Dr. Bloom. Moving on to our next speaker is Dr. Rebecca Lundgren from Georgetown University's Institute of Reproductive Health. Dr. Lundgren is the Deputy Director and Director of Research at the Institute for Reproductive Health, Georgetown University, where she applies her 25 years plus of implementation science experience to the challenge of developing and testing effective, scalable programs for very young adolescents. Rebecca will speak to us on the topic of developmental assets and sexual and reproductive health among VYAs, the case of Northern Uganda. Rebecca?
Great pleasure to be with all of you this morning and my esteemed panelists, colleagues, and friends. Bob has given a very compelling discussion about the various domains that influence boys and girls as they grow up into adults. In fact, there is growing recognition that the best way to achieve our vision of young people with healthy sexual relationships is to support adolescent positive development, sometimes called developmental assets, from a very early age. However, there's very little empirical evidence of the linkages between these developmental assets and sexual and reproductive health outcomes. So the study that I'm going to share with you today was designed to provide some evidence on the linkage between assets and sexual and reproductive health outcomes among this very young age group. The study was conducted by IRH in collaboration with the Search Institute, and it took place in northern Uganda last year. So let's talk a little bit about developmental assets. It's a little bit of a mouthful, but it simply refers to those valuable resources that young people have within themselves and also the context around them, which are key to their well-being and healthy development. One of the ways that we measure developmental assets is the Developmental Assets Profile, or called the DAP, which was developed by the Search Institute and has been tested and used in a number of settings around the world. The DAP measures 8 broad categories of assets, and these are divided into external and internal assets. The external assets are those that are provided by people in the young person's context, like the ones that Bob was mentioning, the family, the community, the school, or their peers. Those are, you can see here on the first column to your left. And then we also have the 4 other assets, which are considered their internal strengths, which those are things related to their values and beliefs that young people have within themselves. Assets can also be understood in terms of the ecological context in which they're built, and you see those on the far right, where you can see some categories that roughly correspond to the circles that Bob just presented. So we look at the personal, social, family, school, and community assets, which is in the world of the DAP, we just rearranged some of the questions and the items into different categories to look at context. Looking at this internal and external assets gives us a really nice tool for looking at adolescent well-being from a holistic point of view. This slide here shows you some of the a number of sample items from the DAP organized by the asset scale and the context scale that it belongs to. Together, these are grouped together to measure larger constructs. What's important for you to know is that in the case of our work in northern Uganda, and everywhere the DAP is applied, it must go through a very rigorous adaptation and testing process to make sure that these items are culturally relevant while remaining true to the original tested assets framework. So we did went through an adaptation and testing process, which included translation, back translation, focus groups, and 2 pilots of the tools. So since we were, of course, wanting to look at the linkage between these assets as measured by the DAP with sexual and reproductive health, we also had to come up with indicators that would be appropriate for this age group. So some of these indicators are indicated here on the slide, and as you can see, they range from knowledge and attitudes to supportive relationships, access to service, and intention to delay sex or use condoms. As many of you know, developing sexual and reproductive health indicators for this age group is not easy, and you may wonder why there are not more questions about sex or condom use or other kinds of behaviors that we're typically interested in our field. So the reason why is that during the pilot, only 3 of the boys interviewed even admitted to having a girlfriend, and 1 of them had ever had sex. So we focused, for this particular population, we focused the DAP on other indicators and not so much on sexual behaviors. That, of course, could be different in different settings. So let's look a little bit at the results and see what we found. We were eager to find out if there was some kind of empirical measurable link between these outcomes and developmental assets. So the data that I'll be presenting is based on the DAP scales and subscales. So it's important for you to know, without belaboring the point, that the revised scales worked well in this setting, and you can see some data on the reliabilities here on this slide. So this slide shows us kind of an overview of what we learned. So where did the young adolescents that we interviewed fall on the DAP? So you can see about 60% of the youth are represented in the 2 highest levels, which we call thriving or adequate. And those are represented by, I guess, the blue and purple slices on the left of your pie. However, a third of the youth did fall into the category of vulnerable and 7% in challenged. There were no significant differences by sex. So I'm not on this indicator, so I'm not presenting it broken down by boys and girls. One thing I forgot to mention earlier, that this study took place in kind of urban Gulu in northern Uganda. So these are not the most rural children. They're kids who are living in pretty much an urban area, but in the setting of kind of remote northern Uganda. So this slide here shows a comparison of the sexual and reproductive health outcomes between girls and boys. Girls are the light blue and boys are the dark blue bars. And what you'll see here is that girls are more likely than boys to have most sexual and reproductive health outcomes. In other words, the girls are doing better on sexual and reproductive health. Almost a quarter of the girls, as compared to only 12% of the boys, for example, reported having a supportive relationship. Similarly, 72% of girls reported accurate knowledge of puberty, as compared to only about half of the boys. So let's go on and look at our hypothesis. Our question was the linkages between these developmental assets and sexual and reproductive health. So this slide shows the results for youth with adequate and thriving levels. And what we see is that they had better odds than other youth in 3 of the 5 outcomes, sexual and reproductive health outcomes that we're measuring. So they were more likely, youth who were adequate or thriving in terms of assets were more likely to have accurate HIV knowledge, believe they can access services, and intend to delay sex until marriage or use condoms. So this slide is looking at just those youth with thriving assets. So those are the youth who are doing the best of our sample. And what we can see here is that they had better odds than all of the other youth in achieving 4 out of the 5 outcomes. So on this slide you can see that more likely to have accurate condom knowledge, HIV knowledge, and more likely to have supportive relationships. So what does this mean for programs? That's really the bottom line. So the results of this study tell us that addressing the vulnerabilities of boys as well as girls is important to improving sexual and reproductive health. In our field, we often neglect boys in our work because of the overwhelming needs that we see in the lives of young girls. Yet these results suggest that fewer boys have supportive relationships, adequate information, and access to services than their female peers. In order to lay the foundation for healthy and sexual reproductive lives, it's time to really think outside of this sexual and reproductive health box of programming. We need to think about programs that build those assets that youth need to successfully navigate puberty. That's not a surprise for those of you listening who are involved in other health areas, but it's something that we in the sexual and reproductive health area have neglected, I think. So we can do that. We can address and build positive assets by improving the ability of parents and adults to support girls and boys, by expanding our rights-based programming to engage young people actively in their communities, build their life skills, and conduct activities to link children with supportive adults. That's a quick snapshot of our results, and we'll be sharing with you a brief that has further information for those of you who are interested. We can go and learn more about the study. Thank you very much.
Thank you, Rebecca. Moving on, Dr. Chandra, scientist at the World Health Organization's Department of Reproductive Health and Research, will be our next speaker. At WHO, Dr. Chandra focuses on building the epidemiologic and evidence base around adolescent sexual and reproductive health and translating that research into well-conceived and well-managed policies and programs. Dr. Chandra will speak to us on menstrual stigma. Why does it matter? Dr. Chandra?
Greetings from WHO. It's a pleasure to be part of this group and part of this discussion. In my brief presentation, I'm going to talk about menstrual stigma. Does it exist and does it matter? I looked at the Merriam-Webster dictionary for a definition of the term stigma. And the dictionary defines stigma as a set of negative beliefs and attitudes that a group or a community or an entire society have about something. The dictionary also says that these beliefs and attitudes are often unfair. And clearly this is in the context of menstrual stigma. Next, please. So does it exist? Working with Sheila Patel and Marnie Sommer, we've just completed a systematic review of the knowledge and understanding of menarche, menstrual hygiene and menstrual health among adolescent girls in low and middle income countries. We've submitted it to the Journal of Adolescent Health. This review identified 110 papers or so from a number of developing countries, over 40 developing countries, 40 low and middle income countries. And in a nutshell, there is stigma. There's an enormous amount of stigma for various reasons. And one is because of the discomfort with it being associated with sexuality and reproduction. It's very difficult for many people, many groups, many communities, many societies to talk about anything related to sexuality and reproduction. Now, this is not just low and middle income countries. This is not just Asian, African, and Latin American countries. There are still many high-income countries in North America and Western Europe where school-based sexuality education is not statutory. And this stems from the same discomfort. The second point is there is stigma because girls themselves feel unable to manage their periods effectively. So there is the sense of shame. I don't have access to menstrual products, and so I use a newspaper or dried leaves, or I don't have underwear to wear and to keep the menstrual products in. And so the shame is associated with the fact that I'm constantly worried whether I'm smelling or I'm spotting. And this is something that comes up again and again in the papers describing menarche and menstruation in adolescent girls. I'm from India, and in South Asia, especially but not only, the stigma is associated with menstruation and menstrual blood being seen as dirty. And so you hear the word pollution and dirt and the word disgust in the discussions, in the discourse. And that translates into action. That's my next slide, but just to summarize, there's an enormous amount of stigma associated with it for a variety of reasons. Now, does it matter? It does matter because of the stigma, girls in South Asia, girls in the Arab world, are often not allowed to pray, not allowed to enter the kitchen and cook, not allowed to sleep in their beds, not allowed to touch any male member of the family because they may pollute the person. So that hinders their ability to carry out everyday activities. There's another huge issue about schools not having functional toilets and girls not being able to go to school because of that. I was struggling with whether that is a result of stigma or not, but it clearly is because of lack of investment and lack of respect and attention to girls' needs. But there are two other issues. You know, hindering the ability of girls to carry out everyday activities is important, but it doesn't kill like maternal mortality or HIV. So why is it a public health issue? It's a public health issue for two reasons. It weakens girls' self-esteem and self-confidence. What we say increasingly is that self-esteem is the basis of good health, good development. And this is, reinforces what Rebecca said in her presentation, feeling good about oneself. So, you know, not knowing whether your periods are going to come today or next week, not knowing whether you can manage your periods, not knowing whether you can take an exam which is next week because you don't know whether your periods will come, absolutely must destroy girls' sense of control and competence. And you hear that message again and again in papers describing this area. The next point is speculation at this stage, but if a girl is told verbally and non-verbally that, you know, menstrual pain, menstrual discomfort is part of her lot and that she shouldn't talk about it to anyone. In some papers you read that no male member of the family is meant to know that you have your periods, although everyone knows you have your periods. So that must hinder a girl's healthcare seeking now and in the future. Are we surprised then that women seek care for cervical cancer or a breast lump late? I want to come back to my second point about weakening self-esteem and self-confidence in my next slide. Could I please have the next slide? This wonderful book, The Teen Years Explained, published by Johns Hopkins Bloomberg School of Public Health, talks about core effects, and you know it comes back again and again, as you will see, to points made by Professor Blum and Professor Lundgren, that you know you need competence, confidence, connections with people and institutions, a sense of right and wrong, a sense of caring. We talk about these as the core assets that we need to help adolescents develop as they make their transition from childhood through adolescence into adulthood. And I've highlighted 2 points in red, and that's competence and confidence. As I said earlier, not knowing whether they can manage their periods, not knowing that they can take charge of themselves is extremely important to one's sense of incompetence or lack of control and lack of confidence. You hear so much in adolescence about the dip in confidence that girls have. Whether this is entirely because of menstruation is not clear at all, but clearly for girls in low and middle income countries, it must contribute to it. My next and last slide, please. So menstrual stigma exists. Menstrual stigma affects girls' lives now and we believe in the future. And it's because of the reasons we've described earlier, but lack of attention to girls' needs and problems is a widespread issue. And it affects many issues, you know, violence, access to contraception, so many other issues. So girls need to be well educated about menstruation. Girls need to grow and develop in a context that sees menstruation as healthy and positive, not shameful and dirty. That's really the central message in this discussion on stigma. The others are about access to the products and services they need to manage themselves well, to be cared for and supported by their families when they have their periods, and to be able to consult a competent and caring health worker when they have problems. So that wraps up my presentation. So I think in the early adolescent period, when we run workshops, my last point is that when we run workshops for health workers on adolescent health, doctors, midwives, nurses, often in their 40s and 50s, we start by asking people to write down one memory from their adolescence which is etched in their minds, which they'll never forget. They do it on a card and put it face down on a table in front of them. And when we cluster the cards in wherever we are in the world, you find 6 or 7 cards about my periods. I had my periods, I didn't know what was going on, I was scared to death, I thought I was going to die. I saw a doctor, the doctor was not sympathetic. I started spotting in class and there were giggles behind me, I didn't know what was going on. This is a huge issue and something that we have to deal with. And for me and us in WHO, this is front and center public health. Thank you.
Thank you, Dr. Chandra. Next on our panelist is Brad Kerner. Brad is the Adolescent Reproductive Health Advisor at Save the Children. He is an international public health specialist with over 15 years experience focusing on adolescent sexual and reproductive health. While we will focus today on a project related to girls' menstrual hygiene management, Brad has a strong passion for bringing boys and men into the sexual and reproductive health dialogue. Today, Brad will cover the topic, private sector investment in menstrual hygiene. Brad?
Thank you so much, and greetings from Save the Children US. While I wait for my slides to come up, I just want to say how happy I am to be here and how pleased I am. I think I see over 130 participants calling in today, so thank you so much for listening in. As noted, I will follow right on the same topic that Chandra just presented on and talk about a partnership with the private sector to address some of these needs around menstrual stigma. Community expectations on how adolescent girls and boys should act and how they should be envisioning their life trajectories are often quite strong and dictated, often with limited roles and opportunities for girls. Providing support and education for very young adolescents is one way to level this playing field. Save the Children has a global commitment to improving the lives of girls and women by addressing gender inequities and engaging men and boys in an effort that will improve community norms in support of children's well-being. We assert that one of the most fascinating times of life to do this work, and one of the most important, is during this early puberty and early adolescent years. Changing perceptions, paradigms, and opportunities early is key to influencing lifelong opportunities and related decision-making. I might need help moving my slides. Thank you. This is Abeba from Ethiopia. Look how happy and carefree she is. Remember those days when you were 11 years old and you felt you could achieve all your hopes and dreams? I wonder what you would write down on that card if you were in that workshop with Dr. Chandra around your greatest memory. The sad reality for so many children is that when they hit early adolescence, many of their life opportunities are cut short because of restrictive social and gender norms. Abeba is on the verge of her first menstruation, but does not know what to expect or what is about to happen because no one has ever talked to her about the changes she is about to experience. And little does she know that this transition to adulthood has triggered her parents to begin negotiations with another family, arranging her marriage. One of the key drivers for her parents' pursuit of an arranged marriage is financial insecurity. They can't afford her. They believe marriage and dependency on another family will afford her a better life and protect her. For Abeba, early adolescence and puberty will quickly propel her into the adult world of marriage, pregnancy, and motherhood. The reality for Abeba and her family is that none of them know how to shift the pendulum, so Abeba's life chances are something that she can influence and change. At Save the Children, we work to slow this progression into adulthood down just a bit, taking a step back and providing very young adolescents, their parents, and their teachers the tools they need to transition and help very young adolescent girls transition through puberty confident, healthy, and informed. So what kind of tools do we offer? Health education, financial literacy, empowerment training through sports, classroom engagement, and literacy. So we're going to dive into the squirmish topic for some, which is menstruation management, as this is one example of several ways that we empower girls. And I think Chandra highlighted nicely why we should start with this, because of that stigma and the effect on girls. Girls' ability to manage menses in school affects the quality and enjoyment of girls' education. Poor menstrual hygiene management in schools causes worry and humiliation, contributes to absenteeism, and leads to poor performance in school. Moreover, as girls transition through puberty and feel shame about their body changes, their lack of confidence becomes increasingly visible. This affects their entire adolescent experience. For the public eye, you don't really need to always call this menstrual management. It depends what context you're working in. You can call it empowering young women. But I push you to remember that in the developing world, what a hurdle this is, this issue of menstrual management, menstrual hygiene management, and consider the value of equipping your programs and the girls you serve with proper latrines, the basic health and hygiene education to ensure that girls know how this transition will impact their future, their family's future, and their life choices, and preventing early and unplanned pregnancy. Next. Oh, I got the next slide. Thanks. So to help drive our agenda on menstrual hygiene management, Save the Children has partnered with Procter & Gamble's Always brand, who for the last 30 years has been championing girls' puberty transition and helps girls have access to information, find the support they need, and to gain confidence. Procter & Gamble now reaches 65 countries through more than 500,000 education professionals for 17 to 20 million girls each year. Helping girls gain confidence is core to their brand. Anyone who has watched the American Super Bowl this year might have seen a great Procter & Gamble commercial about running like a girl, where they effectively and emotionally broke down gender norms and expectations of girls in front of 40 million American viewers, while showing girls that they can do anything they put their minds to it. For those of you not in the U.S., and I think it's the majority of you on the call, I think if you just Google "Run Like a Girl" PNG, this video will come up on YouTube. So through Save the Children and UNESCO and local partners, Procter & Gamble continues this mission in developing countries, so more and more girls will know what is happening to them when they start puberty and have access to menstrual pads where available. We were hoping to have a colleague from Procter & Gamble do this presentation, but then they were not able to join us, so this is why I'm showing a little bit around Procter & Gamble's framework and their achievements. So Save the Children has been a proud partner of Procter & Gamble's Always and Tampax brands since around 2008. We've partnered on a project called Protecting Futures in Ethiopia, South Africa, and Nepal, where we have trained teachers and girl leaders on delivering puberty education. We've built girl-friendly latrines at schools so girls would feel safe and comfortable while menstruating at school and every day, to be honest, and introduce girls to the full range of menstrual hygiene management products available to them in their markets. Through the project, we also were able to develop really nice educational products, like, whoop, I think I'm one slide ahead. So, like this poster you see here on the left. This was written in local languages in all 3 countries and distributed to the girls, and it just had nice inspirational messages on one side that they could hang on their wall, and then on the other side had information about puberty and menstruation. We've also developed puberty workbooks for boys and girls and now are adapting them throughout the global Save the Children movement. And I'm happy to share examples of these from Nepal, Malawi, and Uganda. And we also have a colleague at Columbia University, Marnie Somers. She has developed puberty workbooks as well in about 5 or 6 countries, and we can direct you to her website. We've also expanded our partnership with Procter & Gamble and are now including menstrual hygiene management into our school health and nutrition programs in China, Nigeria, and Mexico. For us, this is a really big opportunity for scale-up, both for Save the Children and Procter & Gamble, because one, it's working directly through the schools on a school health and nutrition platform, which we have very institutionalized through our work, and most ministries of health also have school health and nutrition directors within the Ministry of Education. So it becomes a really nice way to drive some of these issues up through the policy level. Like Procter & Gamble, Save the Children has experienced the pleasure of watching girls gain the confidence in themselves at a time when so many girls start becoming self-conscious of their body changes and start to drop out of school. To hear these 2 girls say that this is information they will talk to their daughters about when they become mothers is already breaking down the long-standing taboos that exist around the world and in their communities. This is the type of shared results and partnerships we seek with our private donors. They're win-win strategies that have shared value for both of our brands. That would be the Save the Children brand and in this case, Procter & Gamble's brand. So this was the part of the webinar where we wanted to show you a video we made on this Protecting Futures project in Nepal and Ethiopia. And unfortunately, we realized too late that showing the video wouldn't be very effective on this platform. So what I would love for everyone to do is pull out a pen. It's a 3-minute video, so instead of spending 3 minutes watching it, I want to take 30 seconds for you all to write down the URL. And it would be great for you to watch this after the webinar. I'm also typing in the chat box a longer URL, which I'm not going to make you write down, but you can cut and paste it, and that will bring you to our website. It's a microsite all around this Procter & Gamble Protecting Futures partnership, and there's some videos there. So just a few concluding remarks. Save the Children strategically invests in very young adolescents, and we recognize the critical importance of this transformative time when girls' life's opportunities can be determined and their course to adulthood shaped. When properly supported, girls can stay in school, delay marriage and childbirth, acquire strong life and livelihood skills, and safely grow into healthy and educated women who make powerful and positive contributions to their families and communities. But when girls receive little or no support, life options narrow as opportunities are replaced by dropping out of school, early marriage, early childbirth, and perpetuating a cycle of poverty. So at Save the Children, we are already reaching these children through education, empowerment, health, and livelihood programs in over 20 countries. Our biggest challenge now, and it's an opportunity that we have, is currently testing out a multi-sector platform and programming all together in one package for very young adolescents, with the goal of improving sexual reproductive health, educational attainment, and well-being as very young adolescents grow up through older adolescence. And this is really where we're seeking our biggest partnership opportunities for the moment, is looking beyond single thematic areas, but doing a much more comprehensive package of child protection, education, and health for younger adolescents to support these transitions. Thank you so much for listening in, and I'll hand it back to the moderator.
Thank you, Brad. Moving on to our last speaker, Sadvika Shalasani, Technical Specialist at UNFPA. Ms. Shalasani works on the sexual and reproductive health and rights of adolescents and youth with a particular focus on the poorest adolescent girls. Ms. Shalasani will speak to us today on childhood and motherhood, the need to invest in VYAs.
Thank you, Danielle. and thank you everyone for listening in today. I would like to quickly talk about adolescent pregnancy, bringing it around full circle to where Dr. Bloom started this morning, and how investing in very young adolescents can support their safe transitions to adulthood, including in marriage and childbearing. You've already seen some data presented by Dr. Bloom, and some of my data repeats what he has said. However, I think it's an important point, and so I would like to note that in more than 30 countries, 10% or more of adolescents have had sexual intercourse by age 15. That means that adolescents transition early to sexual activity. In some countries like Niger, those rates are as high as 26%. In Niger, of course, most of it is within the context of marriage, and you actually see this very rapid cohort progression into marriage, where by age 15, while you have about 11% married, this is women 20 to 24 married by age 15, about 11%. By the time you get to age 18, 3 short years later, you have 3 times the number of girls who have entered into a marriage or a union. So there's very early and rapid transitions into marriage and childbearing in many countries. Around the transitions into marriage and childbearing, the important point to note is this distinction about sexual initiation before marriage and after marriage. The UN Population Division has a study in which they compile data from about 36 countries, mostly African and Latin American. And from that data, you see that in 22 of the 36 countries, sexual initiation is actually more common before marriage than it is within marriage. However, I would like to note that data on the sequencing of these activities does rely on date reporting, which is not always of the best quality. And there is a certain simultaneity or jointness of decisions in activities related to sex and marriage and childbearing. And it's hard to kind of sequence these out, even though we do try to do this with surveys. That being said, given that sexual initiation does happen before marriage in many places around the world, most childbearing does happen within marriage or union. As Dr. Bloom said this morning, that's 90%, or 9 in 10 adolescent births happen within the context of a marriage or union. And adolescent childbearing, as he noted, while it's been declining, it's still very high. About 19% of young women in developing countries give birth before age 18. That's 7.3 million births a year, of which very young adolescents, those under 15, actually contribute 2 million. So that's more than a quarter. And just a different way of slicing the data, that's about 20,000 girls each day giving birth before the age of 18. There's also significant differentials between countries. If you look at the regional estimates on adolescent birth rates, the world average is 50 births per 1,000 women 15 to 19. In the least developed countries, it's about 113 births per 1,000 women. In the more developed countries, it's 21. That's a differential of 5 to 6 times between these two regions. The issue with the early transitions to sexual activity, marriage, and childbearing is that a lot of these are unintended and unsafe. We know that a lot of sexual initiation is actually forced or coerced. In high adolescent birth rate countries, about 30% of births to women under age 20 are unintended. That's the median. Of course, when we say unintended, because these are young adolescents and they do want to have children at some point in their life, most of the unintended births are actually mistimed rather than unwanted. 3.2 million unsafe abortions occur each year among girls 15 to 19. We don't have very good data on abortions among 10 to 14-year-olds. And there are 70,000 adolescent deaths annually from complications related to pregnancy and childbirth. As a new WHO report from last year shows, it's the second leading cause of death among females 15 to 19. So the point of showing that data was to show that there are these early transitions, rapid transitions, many of them with serious consequences, and they're unsafe and unintended. We do have some theoretical frameworks for understanding how young is too young for these transitions, because adolescents do have to make these transitions at some point. And you can look at the physiological maturation of the body as one criteria, cognitive capacity for making safe, informed, and voluntary decisions, and institutionalized concepts of old enough as reflected in legal frameworks and international standards. And if you use those three criteria and you look at the timing of transitions and the context of those transitions from DHS data, which tell you something but not everything about these transitions, the conclusion is that boys and girls aged 14 and younger are universally too young to make safe and consensual transitions. So what we understand from theory is borne out by the data that we see, and we know from large quantitative studies but also qualitative studies around the context of these transitions. So what will it take to ensure that these transitions happen when adolescents are old enough and when they want them to occur? It will mean we have to empower girls with information, skills, and support networks, including comprehensive sexuality education. We have to enhance the accessibility and quality of formal schooling for girls, including conditional cash transfers. Their families must have economic support and incentives, including unconditional cash transfers. We must make available quality, affordable health services, including general preventive services for younger adolescents and contraceptives, HIV testing, counseling, and treatment, and maternal health services for older adolescents. We also need to ensure that the laws on minimum age at marriage are set to 18 and that access to SRH services is non-discriminatory and there's no restrictions based on age or marital status. Early adolescence, to reiterate, the whole purpose of this webinar is critical. Globally, 32% of girls of lower secondary school age are out of school. What this means is that primary school completion, transition to secondary school, these occur around the same age as puberty, as when puberty hits. And investing in girls before puberty and school dropout occur is key. All of the interventions that I talked about in the previous slide, these need to happen earlier and earlier, as early as we can let our conscience and our programs allow them to happen. And so I would like to conclude there by saying that we know a lot about the transitions adolescents make, especially in the domain of SRH, and we know that we need to make preventive investments in very young adolescents to ensure that these transitions are safe and consensual. Thank you.
Thank you, Sadvika, and thank you to all of our speakers today. So what's next? As I mentioned earlier, we would like to take this opportunity to launch the K4 Health VYA Clearinghouse Toolkit. This toolkit is for program managers, educators, health workers, advocates, researchers, and policymakers committed to making a difference in the lives of very young adolescents, girls and boys between the ages of 10 and 14. The toolkit offers resources which address the unique developmental, cognitive, and social opportunities and challenges facing this age group. It provides links to examples of successful programs, research results, curricula, advocacy materials, and other resources useful for working with VYA. In addition, the VYA is planning to do another webinar, and in the next 4 to 6 months, we welcome your to learn and hear about on VYAs. After this webinar, we will be sending out a short survey, only about 4 questions, asking for your ideas and on topics that you would like to see for future webinars. Tomorrow, we will be sending a follow-up email with resources referenced to, I know some of you have asked about this, referenced in today's presentations, along with the link to the toolkit I just mentioned. On behalf of the VYA Alliance, I would like to thank you for joining us today for our first webinar, and we look forward to having you join our future webinars. So please stay tuned, and we look forward to our next time. Thank you.